Hello, this is Dr. Kevin Kirby, and I want to talk to you now about part two of my series on the medial and lateral heel scuff techniques. Richard Blake was my biomechanics fellow in my second year of podiatry school, and during that time, Dr. Blake was experimenting with this Blake inverted orthotic technique on many of the runners he was seeing in his clinic and at the podiatry school. And what I personally saw of the root orthotic versus the Blake inverted orthotic, which used high degrees of inverted heel technique, was that the Blake inverted technique was superior at controlling excessive pronation in patients' feet, whether they were walking or running. And this technique used by Dr. Blake was quite a significant departure from the standard root orthotic and the dogmatic teachings of root that an orthotic had to be a certain way in order to work correctly. At the time, though, there was no real coherent mechanical explanation as to why the Blake inverted orthotic technique had worked so well for the patients that he was using this on. And this is what drove me during my biomechanics fellowship to search for a better answer or a better explanation as to why the Blake inverted technique worked well. So I'll do a little review on some of the work that I had done early on the subtalar joint axis and its location. Again, for review, remember that the subtalar joint axis passes out through the anterior dorsal neck of the talus, and as the foot supinates, it externally rotates and laterally translates, and as it pronates and the talus shifts medially and rotates internally, the axis of the subtalar joint also internally rotates and medially translates. So we see in these videos of this subtalar joint axis locator that Dr. Simon Spooner and I worked on and wrote a paper on in 2006. We can see this wand here following the subtalar joint axis in supination here, and then pronation, and then supination and pronation, and then here supination and pronation. So these are the movements of the subtalar joint axis during weight-bearing activities of the subtalar joint in a closed kinetic chain. Then around in 1990, I helped develop the supination resistance test as a way to try to assess the internal forces required by the posterior tibial muscle and tendon in order to supinate the foot. This is a test that I actually started experimenting on during my biomechanics fellowship back in 1984, 1985, and this was first published in my chapter I did with Don Green in De Valentine's book, published in 1992. So basically in this test, the patients are required to stand in a bipedal fashion, resting. I place the tips of my fingers underneath the medial navicular and lift upwards to assess the amount of force required to supinate the foot. What I saw over time was that as the axis was more medially deviated of the subtalar joint, this required more force to supinate the foot, regardless of the body weight of the patient. Also around the same time in my biomechanics fellowship in 1984-1985, I developed the maximum pronation test as a way to try to assess whether the patient is maximally pronated or not. In this test, we have the patient stand, activate their perineal muscles in order to produce a maximally pronated position, and assess how much movement that the subtalar joint had moved and the heel had everted. If the heel everts less than 2 degrees during this test, I assumed the subtalar joint was maximally pronated. Also, I had published some research along with doctors Pascual Herrera and Ropa Moreno from Spain for seeing how frontal plane wedges affected two groups of patients, either non-maximally pronated or maximally pronated. Again, a review: as the subtalar joint becomes more medially deviated, ground reaction force underneath the heel has less supination moment effect, and ground reaction force underneath the lateral forefoot causes more pronation effect. And this is what we see in the flat feet that we use this heel scuff for in treating their symptoms and their gait abnormalities. Again, also, as I mentioned in the last lecture, the extrinsic muscles of the foot are going to be severely disadvantaged to produce supination moments when the axis becomes more medially deviated, as we can see on the right here compared to the left, where the axis splits the distance of the foot into basically two halves, where in the medial axis foot, very little of the foot is medial to the axis to produce supination, and much greater amounts of the foot are lateral to the axis to produce a pronation moment. During this time, when I was thinking about the subtalar axis and how you had to be medial to the subtalar joint in order to produce supination, and using the supination resistance test and the maximum pronation test, I started to become aware, along with my experience of using the Blake inverted orthotic, that possibly a medial heel skive would be a better way of producing the effects of the Blake inverted orthotic technique without the complex positive cast modifications that were required to produce the Blake inverted orthotic technique. With this subtalar axis location idea that I came up with and started doing on all my patients and all my students I was teaching at the time, gave me a better idea of how this Blake inverted orthotic technique worked, and how I could use then a new technique to produce what I thought was a better way of controlling pronation of the foot. So in about 1990, I started experimenting with a technique where we took the positive cast and removed 2, 4, or 6 millimeters of plaster from the medial heel into a 15-degree angulation and beveled it into a medial heel skive, which produced an intrinsic varus wedge within the heel cup of the resultant orthotic. After approximately a year of using that on my own patients, along with Precision Intracast Lab, we determined that this was a safe technique, and we started offering it to all the other doctors who use Precision Labs as a way to produce better pronation control on the foot. I sent the paper in for publication in 1991 on the medial heel skive technique, and it was published in 1992. Again, a medial heel skive technique allows for very precise amounts of varus wedging to be placed into the heel cup or the orthosis. It along with the medial arch height increase, which I also use with medial heel skive, is used to increase the forces medial to the subtalar axis, both in the heel and with the medial arch bar in the medial arch area of the foot, in order to produce more of a supination effect. And this medial heel skive technique, which I first started working on in 1990, is now being used worldwide, not only in custom orthosis, but also in over-the-counter foot orthosis. So what are the biomechanical effects of the medial heel skive? Well, the typical root orthotic, if we look at this model here, here's our tibia and talus as one unit, the subtalar axis in the center, and our calcaneus, and here's medial, here's lateral. A typical root orthosis is going to press in the central aspect of the heel, so it has only a slight amount of supination force at the subtalar joint. However, if we have a foot with a medially deviated subtalar axis here, and here we see the axis has been shifted medially compared to the normal foot, is when we use that root orthosis, the force from the root orthosis does not give us much supination moment. However, if we were to use a medial heel skive, what that does is transfers the center of force from the orthosis more medially, and this produces an increase in supination moment medial to the subtalar axis. So it's this medial shift of the ground direction of force of the medial heel skive orthotic that results in the increased external subtalar supination moment that is evident when we're using this medial heel skive on our patients who have pronation-related pathologies. One of the interesting phenomena in exploring the subtalar axis location and medial heel skive is that it became apparent right away that in the patient that had a medial axis, we had a very small surface area by which to supinate the foot. So if we look at this foot that's medially deviated, this is a pes planus foot, and we see the axis medially deviated, we have a very small surface area here to produce supination moment, and a much larger surface area plantar to the foot to produce pronation moment. In the normal axis location foot, actually the foot is split into a medial half and a lateral half fairly equally by the location of the subtalar axis. In other words, in the normal foot, about half the foot is medial to the subtalar axis, and the other half of the surface area of the foot is split lateral to the axis, producing pronation moment. But we see in this medial axis foot, we have about a quarter of the foot medial to the subtotal axis, and approximately 3/4 of the foot is lateral to the subtotal axis, which causes pronation moment from ground reaction force. This decreased supination area of the orthosis in the foot that has a medially deviated subtotal axis creates problems with trying to control the foot with a orthosis, and this is the reason the medial heel scav is so effective, because this medial heel is a very effective area to produce a supination moment on the foot. As I said before, the medial heel scav should be used together with increased arch height of the orthosis in order to optimize the pronation controlling ability of the orthosis. We use the heel scav to add a supination moment in the rear part of the foot in the heel, and then we'll use the arch height stiffness or arch height of the orthosis in order to increase the ground reaction force plantar to the medial arch so that there's less pronation moment coming from the ground. So we basically want to distribute pressure away from the lateral aspect of the plantar foot, shift it medially, and the plantar rear foot, midfoot, and sometimes even the forefoot. So this combination of both medial heel scav and lateral and medial arch height are important in order to produce the effects we need from the orthosis. Again, here's some slides, F-scan slides from Bruce Williams in Indiana, showing a posterior tibial tendon dysfunction foot with shoes only. And here's a posterior tibial tendon dysfunction foot with an orthosis that has a medial heel scav. We can see the red areas here, which are high pressure areas showing increased pressure. So there has been some research on medial heel scav technique. Daniel Bonanno and his group in 2012 published research on the medial heel scav technique. The amount of medial heel scav used was 2 millimeters, 4 millimeters, and 6 millimeters. And what they found was that when using this medial heel scav technique, we were able to produce a large increase in medial heel pressures here, very significant for the 4 millimeter scav, 15%, and peak pressures increased by 29% with the 6 millimeter scav, which is exactly what I predicted in my paper from 1992, that higher degrees of scav would produce higher pressures or ground reaction force medial to the subtotal axis at the heel area of the foot. There is also another paper just published in 2017, which looked at a group of patients with patellofemoral pain syndrome. 14 subjects were treated with medial heel scav orthotics and followed for 4 weeks, and the improvement in pain in these patients was much greater than with a medial heel scav orthosis than not having that treatment. So this improvement in pain with the medial heel scav orthotic technique and treating these patients with patellofemoral pain syndrome is further support for its use, other than the multiple podiatrists who have used this technique over the past nearly 30 years in treating patients who have pronation-related pathologies of the foot and lower extremity. So in conclusion, my observation of Dr. Richard Blake inverted orthotic technique at improving pronation control required a mechanical explanation, which was not present at the time that he first started using the Blake inverted technique back in the early 1980s. I developed the medial heel scav technique in 1990 as an alternative to the Blake inverted orthosis, which required less cast construction techniques and allowed, I thought, more precise modification of the ground reaction forces in the medial heel, along with being able to independently control the arch height by inverting or everting the orthosis or making the arch higher by using a minimal arch fill on the positive cast in order to both control the medial heel pressure but also the arch pressure in order to increase the supination moment more effectively in patients with pronation-related pathologies. And it is now evident that the medial heel scav technique is used both in custom orthoses and in over-the-counter orthoses worldwide, and that in trying to understand how this works is important for us to be able to understand how we can best treat these patients who have pronation-related pathologies of their foot and lower extremities. Thank you again for your attention, and I'm hoping you're enjoying these lectures.